Thank you, everyone, for joining. Welcome to my presentation. My presentation will be on critical care in low resource settings. I am Dr. Menbeu Sultan. I am an emergency physician, an intensivist working at St. Paul Hospital Millennium Medical College in Addis Ababa, Ethiopia. As you know, Ethiopia is an East African country. So, of course, part of the low resource setting. And so we will see the critical care in low resource settings. The objectives of my presentation will be how is the capacity of critical care in low resource setting, and we will try to see barriers to critical care treatment in low resource settings, and what are the alternative options to critical care in low resource setting in management of critically ill patients. And we will have a prototype case, which is sepsis. So we will see the management of sepsis and the alternative management in low resource setting with its problem. So let's see the definition of critical care. So the World Federation and Society of Intensive and Critical Care Medicine define critical care as it is a comprehensive management of patients having or at risk of developing acute life-threatening organ dysfunction. So these patients have either a life-threatening organ dysfunction or they are at risk of developing organ dysfunction and death. So mostly these patients are managed in intensive care unit in dedicated area, but we'll see the situation in low resource settings. So infrastructure-wise, in low resource settings, you will have severe shortage of ICU beds, and sometimes those ICU rooms are not designed for critically ill patients, or they are not designed for ICU. So one study have shown the number of ICU beds in a low resource setting may compared to the high resource setting, it is 45-fold the difference between the high income and the low income settings. You see in this graph, the high income settings like Germany and Belgium will have around 30 beds per 100,000 population, and few African countries are mentioned here like South Africa. They have less than 4 ICU bed per 100,000 population. You can imagine in low resource settings like Ethiopia, we have almost 0.04 beds per 100,000 population. And so there is severe shortage of ICU beds. So patients are, sorry, patients are being managed outside of ICU, elsewhere in emergency or in the wards. And you can see these ICUs are not designed for critically ill patients. They are very crowded. This is a photo taken in one of the public ICU in Ethiopia. So you can see how crowded it is, how unclean it is, and the resources. You can see that your crash cuts. You may have ultrasound, but the cleanness of the area and the standard of ICU will be poor. This is also taken from some northern part of Ethiopia. And you can see these cylinders are in the corridors of ICU. You can imagine the shortage of oxygen, how crowded the ICU are, how they are not clean, and this kind of ICU are the norms in low resource settings. So patients, large proportion of critically ill patients will be managed elsewhere outside of the ICU. And these patients are not being managed by intensivists and sometimes by not by physicians. You don't expect intensivists and ICU trained physicians and professionals in low resource settings. So you need to improve the skill of emergency and other professional in handling critically ill patients. And there is also poor continuity of care. These critically ill patients require a good continuity of care, from identification of critically ill patients, transportation of critically ill patients in the pre-hospital setting, emergency room handling of critically ill patients, and transporting to the operation theater, probably continuity is poor, and transporting to the ICU. So that continuity of care should be also improved in low resource settings. Epidemiologically, as you know, the patients population of low to middle income countries almost more than two-thirds, almost 80% of the population in the world is living in low to middle income countries. And this patient population is the youngest population in the world. So low resource settings have high birth rate, probably with high mortality. So you can imagine the population is younger. So those patients being admitted to ICU are also younger, and almost 50% of your patients will have either respiratory failure, head injury, and sepsis and septic shock because of different site of infection. The other common causes like pneumonia, acute renal failure, and pulmonary edema, hemorrhagic shock, and tropical fevers, including malaria, dengue fever, and the others also you have to expect in low resource settings, and obstetric related complication like the eclampsia, preeclampsia, and hemorrhage, postpartum hemorrhage. This kind of patients and cardiac patients with obstetric complication are the epidemiology in low resource settings. So when you see the mortality in low resource settings, it is high. So in one study, the mortality in low resource setting, it's 35.3% as compared to 16% in high income countries. And if you have sepsis, the mortality in sepsis is twice as high as the high income country. And in Ethiopia, the sepsis septic shock patient mortality is too high, close to 70%. So you will have high mortality in a low-income country, and respiratory failure patient mortality is high. It may reach up to 70%, and some studies reported 46%. And if the patient is admitted from wards, the complication rate is high and the mortality is high, around 64%. And if the patient develop complication in the ICU, his mortality will be higher, around 63%. So in general, the mortality in low-income country is higher than the high-income country. Let's have one case and see this is typically our patient in our emergency room, and we'll see how we manage and the challenges in managing this kind of patient. So this is a 30 years old female patient presented from rural Ethiopia with dysuria and fever of 6 days duration after delivery. She has fever, dysuria, and some mental status change. Her vitals at the emergency room, she is tachycardic, 120 per minute, and blood pressure was 80 by 50. She was hypotensive, and respiratory rate was 34. She was a bit tachypneic, and saturation was 80% in room air. So she's hypoxic, tachypneic, with altered mental status and agitation, some mental status change. So as you see, this is a post-delivery patient with fever. It's a puerperal sepsis. She is having also hypotension, tachypnea with desaturation, and some mental status change. So this is a sepsis, septic shock patient with puerperal sepsis. So she has probably pyelonephritis or pelvic infection. And she has multi-organ involvement, including encephalopathy, some mental status change, respiratory failure, she's desaturating, and probably ARDS. Of course, in ARDS definition in low resource setting, you have to use a Kigali definition, which is the division of saturation 80% with FiO2, like this patient, if it is in room air, you have to divide it with 0.21. So this patient probably have ARDS. If the other parameters like bilateral chest X-ray infiltrate and cardiac, the normal left atrial pressure is fulfilled. So sepsis is defined as life-threatening organ dysfunction caused by dysregulated host immune response. This is definition from surviving sepsis campaign. So this patient have pelvic or renal infection and with organ involvement. So this patient has septic shock. So this patient in our emergency was kept in our emergency, which is a norm in our center because of the shortage of bed. And she was investigated. She was WBC was raised 17,000. She was her platelet is 100,000 and hematocrit was 28. This a bit anemic and thrombocytopenic. Other organ function tests were normal. Chest X-ray has bilateral infiltration on ultrasound. This patient had consolidative changes, signs of ARDS on the chest. Otherwise, pelvic and abdominal ultrasound were normal, except the enlarged uterus. So, challenges, an early challenge in this patient, you may have nowhere to admit this patient. So you have to manage this kind of patient in an emergency room. So you may need to manage this patient either in emergency room or in irregular wards. And there will be delay in emergency room for admission to ICU. So of course, in higher income settings, they say increasing in ICU mortality for each hour delay in ICU admission. So surviving sepsis campaign recommends this kind of patient to be admitted to ICU within 6 hours. Of course, you will not get ICU bed within 6 hours. So the ED professional, emergency room professionals, emergency room nurses should be capable of handling this kind of patient. So you need to manage this patient for prolonged time until you get ICU bed or until you transfer this patient. So this 6 hours time may not work in low resource setting. You have to manage this kind of patient in emergency room. So of course, the continuity of care will be poor. Patient may be pre-hospital care was poor. She was delayed at home for decision to be transferred to hospital. Pre-hospital care may be poor. So they recommend there is reduced mortality in early detection and management of sepsis. So they recommended the screening tool for sepsis to improve the continuity of care. Like previously, we were using QSOFA, but recently QSOFA only may not be a good sensitive way of screening for sepsis. You have to merge it with SIRS and other method like MUSE or NEWS. So in low resource setting, you have to have your own way of identifying different kind of conditions, including sepsis. Otherwise, the high income adapting the guidelines from high income countries may not work, and you will lose your patients. So this patient require initial airway and oxygenation. This patient some encephalopathy with hypoxia. You may get nasal cannula, a face mask. Sometimes you may not. These are reusable in a low resource setting. You have to learn how to clean it and reuse this kind of things as compared to high income settings where you have to have one face mask or nasal prongs for individual patients. And oxygen is unreliable in these settings. So most hospitals do not produce oxygen in their compound. So high flow oxygen utilization is very low because high flow nasal cannula will use up to 60 liters per minute. So you can imagine the oxygen consumption. So it is unlikely you are going to use it in your low resource setting. So wall mount oxygen, you may not get wall mount oxygen. So cylinders or sometimes also concentrators are the one which are being used in low resource settings. So you have to learn how to use these things also. So you may decide to proceed intubation of this patient. So when you decide for intubation of this patient, you may get shortage of mechanical ventilator. In one study, only close to 60% of the ICU beds had mechanical ventilator. So there will be shortage of mechanical ventilation and no respiratory therapists and nurses to care for mechanical ventilator. So emergency room physician and the physicians in general should be capable of handling mechanical ventilator also. You may not get support and you have to expect high mortality in intubated patients. In one study, there was high mortality close to 70% as compared to 30% mortality in ARDS patients in low resource setting. So also you will get high VAP rate because of the poor nursing support for patient care, suctioning, and adhering for VAP bundle. So you will have high ventilator-associated pneumonia in intubating this kind of patient. Other challenges in equipment in ICU or in caring critically ill patients will be you will get multiple branded mechanical ventilator with different language. So you have to know this may be difficult to use. Sometimes it's mechanical ventilator. So biomedical support will be poor. Preventive maintenance will be poor. The biomedical support will be poor. So getting experienced biomedical professional may be poor. You may need to use tubings. At time we were using endotracheal tube. We are reusing endotracheal tube. Currently, I think it has improved, but circuits and a different tubing, you have to able to disinfect and use it for multiple patients. So you will have unreliable oxygen supply because oxygen production plant will be in different city, so transportation will be difficult. So inconsistent electricity is the other challenge in low resource settings. So there will be oxygen, electricity interruption. and suctioning and other consumable will be poor. So equipment purchase and availability also should consider this: electricity, oxygen, medical air, your ventilators. You may not get medical air, so you have to have ventilators with a capacity to have a concentration capacity with room air rather than the medical air. So you have to be familiar with available medications, paralytic and sedative medication. You may not get the ideal medication, like you may not get rocuronium, and for sedation, you may not get fentanyl. So you have to use and you have to learn to use the available sedative and paralytic drugs. You have to be familiar with direct laryngoscopy, glidoscope, or the video laryngoscopy may not be available. So direct laryngoscopy will be the first line for intubation. So you have to learn how to use it, and confirmation of ET tube. You may not get end-tidal carbon dioxide. So you have to rely on your clinical decision, including the 5-point auscultation, the condensation, patient improvement, direct visualization, and the other clinical parameter rather than the technology. This patient, of course, after intubation, ventilation, consideration, you may need to use antibiotic. So medication availability may be difficult, like time to antibiotic is 1 hour. In low resource setting, you may not get antibiotic within 1 hour. And you may not know your antibiogram, whether MRSA prevalence is high or not. So to decide MRSA coverage. So you have to have your own protocol in your setting. So source control may be difficult, and de-escalation, antibiotic de-escalation depends on the antibiogram or your culture. So getting culture and sensitivity may be difficult. Reliability may be difficult because of the sampling problem and the investigation problem. So you will have this challenge in low resource settings. And in using vasopressors, so the first line is noradrenaline, let's say. You may not get the first line medication, or it may be expensive because everywhere in the world this medication will be in need. So because of the high demand, it may be expensive to use it in low resource settings. So you have to learn using vasopressors like adrenaline, dopamine, because of their cost. Vasopressin also may be difficult to get. So you may need to support critically ill patients. You may need to support their organ other than their respiratory support. Let's say you need to support the kidney. Sepsis patient may develop renal failure, of course. Sometimes in some settings, 1/4 of the sepsis septic shock patient will develop some form of kidney problem, acute renal failure. So if you need dialysis in low resource setting, you may not get dialysis in every ICU and in every hospital. In Ethiopia, of course, this was 2-3 years ago, and only 4 ICUs had dialysis capacity. So you need to focus on prevention of your kidney failure and supporting the kidney other than dialysis. And you need to get prepared for transporting a critically ill patient to dialysis center. So you have to have your catchment area, and you have to get prepared where to transfer your patient if this patient requires dialysis or other organ support like the liver transplant and all. So this may be difficult to have more organ support in low resource settings. The other problem is shortage of resource. We have seen until now different shortage of resources. And septic patient, as you know, monitoring is very important. So, of course, during fluid administration, also the dynamic methods were recommended. But even the basic monitoring devices may be in shortage. So only 32% of our ICUs had good basic monitoring devices. And invasive monitoring, it is so difficult, unthinkable sometimes to get invasive monitoring to measure the dynamic methods of hemodynamic monitoring. So dialysis capacity also we have seen it's poor. So you have to rely in basic monitoring capacities like pulse oximetry. You may not get arterial line, ABGs. You may not get ABGs. Invasive monitoring are difficult. Central monitoring capacity will be difficult. ABG wise, you may get the machine, but reagent availability is too difficult. Sometimes it may be difficult, it may be expensive. So you have to rely on your clinical judgment in the management of patient in low resource setting, and sometimes trend analysis, continuous monitoring of your patient, continuous availability of the nurses, and early detection, early clinical deterioration, vital sign deterioration. You have to see your monitor, pulse oximetry, heart rate, respiratory rate, and this basic monitoring parameter rather than relying on the advanced mode of monitoring in low resource setting. So in general, the take-home points are you have to predict the unpredictable. In low resource settings, things may be unpredictable. You may not get the ideal equipment, the ideal medication you expect. So you have to expect, you have to predict the unpredictable. Unpredictable environment is the common scenario. Shortage of space. So patients may be managed outside of ICU, in emergency room. So there should be a policy or a way to improve healthcare professional outside of the ICU to manage critically ill patients, to identify critically ill patients early and improve continuity of care, and be capable of managing critically ill patients in emergency room too. So be familiar with resource and tool you have. So if you are trained in high resource settings, to practice in low resource settings, you need to be familiar in equipments, and sometimes innovative way of using equipment may be very important. And you have to expect high mortality in critically ill patients in low resource settings, and rely on your clinical evaluation. So clinical evaluation is very important. Thank you everyone for attending this session. Of course, it's a short session. If you need any further information, how we are practicing in Africa, in low resource setting in Ethiopia, or if you need a further information, I'm so happy to respond. So this is my email, it's menbeu@yahoo.com, and WhatsApp and Telegram number will be here. I am based in Addis Ababa, Ethiopia. Thank you very much. Thank you.